Hello, good morning. I think there's quite a few people in, so let's make a start. My name is Laila Adwan Kamara, and I'm team lead on Ghana Somubi Dwumadie, also known as Ghana Participation Programme. And I'm really delighted to welcome all of the attendees to today's webinar on behalf of the programme. And I think it's going to be a really exciting webinar today. We're going to be talking about developing and implementing district mental health care plans and some of the lessons from our work in Ghana. Now, I'm just going to briefly cover housekeeping issues, and then I will introduce and hand over to our moderator for today, Professor Crick Lund. I just want people to know that we've enabled closed captions. So this means if you look at the bottom of your toolbar, there's a little icon saying CC. And if you click on that, you'll be able to get subtitles coming up to help with any issues with sound that you might be having. And then you can also please use the chat function. That's the one with a single speech bubble. Use the chat function to talk to us, share your reflections, introduce yourselves to each other. That will be wonderful. And if you have a specific question for one of our speakers today, please do use the Q&A button. It really helps us if you use the Q&A, because that way we can see your questions. If you just put the question in the chat, we might miss it, which we wouldn't want to do. Okay, so I would really like to hand over to Crick Lund now. Crick is Professor of Global Mental Health and Development at King's College London, and he's Honorary Professor of Public Mental Health at the University of Cape Town. His research interests lie in mental health policy, service planning, and the relationship between poverty and mental health in low and middle income countries. And if I could just add as well, what a pleasure it's been working with Crick over the last 4.5 years as part of Ghana Somubi Dwumadie. Crick, thank you so much for your contributions. And I'm now handing over the reins of this webinar to you.
Great. Thank you so much, Laila, and good morning, good afternoon, good evening, everybody, wherever you are in the world. It's really wonderful that you've been able to join us today. And we are very excited to be sharing with you the results of 4.5 years of work, working with a number of different stakeholders in a number of different sectors of Ghanaian society. And really testing and implementing models of integrating mental health into primary care through district-level mental health care planning. And so we're going to hear from 3 of the key leaders who have been involved in this aspect of the Ghana Somubi Dwumadie's program. And then we'll have some time for some Q&A after the presentations. So let me just begin by introducing our speakers. Firstly, Dr. Benedict Weerboom is Associate Professor of Global Mental Health at York University in Canada and Fellow of the Dardella Institute. His research interests lie in the epidemiology of mental, neurological, and substance use conditions, developing and evaluating psychological treatments, implementation research to scale up evidence-based interventions for mental disorders in routine primary healthcare settings, and also school-based health and well-being programs. So Dr. Weerboom brings a wealth of experience in these various areas, and we're looking forward to hearing from him shortly. Second up, we have Dr. Kenneth Aye Ngibise. He is a technical advisor on the Ghana Somubi Dwumadie program. He is a research scientist with expertise in psychology and epidemiology, with over 15 years of experience in epidemiology research. And Ken is interested in mental health policy development and implementation in low-income countries. He also has a wealth of experience to bring. And then our final speaker is Lionel Saiki, who is research coordinator for the King's College London team and for the program. He's been responsible for coordinating and providing support for the implementation, monitoring, and evaluation of district mental health care plans. Lionel's interests are in mental health and community-based interventions, rights-based approaches, and policy responses to mental health in Ghana. So we're looking forward to hearing from each of the speakers, and after that, we'll have an opportunity to hear all of your questions and respond. As Lila mentioned, please do post those in the Q&A at the bottom of your screen. And if things occur to you during the course of the presentations, please feel free to go ahead and post those questions, and we'll pick up on them at the end of the presentations. So I'm going to ask Cheryl to run the presentations now, and then we'll open it up for discussion. Thank you very much.
Hello, everyone. My name is Benedict, and I'm glad to be here as my colleagues Kenneth and Lionel. And we're here to share with you in this webinar our thoughts on how we went about developing and implementing district mental health care plans in Ghana. The talk is structured, and so we will take you through an overview of the Ghana Somubi Dwumadie program, and we'll do a deep dive into our district mental health care plans, talking you through the development process, training, supervision, and everything along that line, and obviously share with you our key findings in terms of our experiences. So what at all is the Ghana Somubi Dwumadie program? Ghana Somubi Dwumadie translates into English as Ghana Participation Program. That's Somubi Dwumadie is a Twi word. There are 3 words. Twi is the widely spoken language in Ghana, it's for those who know. And so this program really is a 4-year disability program with a specific focus on scaling up mental health services. And the program is run by Options-led consortium consisting of Basic Needs Ghana, Sight Savers, Tropical Health, and King's College London. It's funded with UK aid from the UK government, and this is how you would find Ghana Somubi quite active on the social media. You can find Ghana Somubi on Facebook, on X, on Instagram, and of course some very useful videos on YouTube as well. So definitely do make time to follow the program. Right. So essentially, I want to share with you what really motivated this story, what really motivated this program of work that we and my colleagues led. We were trying to essentially address the challenges, the biggest challenge that we all know, particularly in the global south and Islamic settings, where majority of persons with mental, neurological, and substance use conditions do not get the treatment they deserve. And that is really what informed this whole program of what do we do, what ways can we employ, what ways can we deploy to try to, if you like, narrow this treatment gap, which is almost 100% in Ghana, to be honest with you, and very comparable to what you find in LMICs, and that's why we very much know. So what was the approach? And that's what I will be discussing with you shortly in the next couple of slides. So the approach was really to learn from best practices, existing best practices. And we did find that district mental health care plans, there's demonstrable evidence from the PRIME program that they do work and they are useful. And we learned further on the reason why that is the case. We learned that they are very, very suitable for local district planning, and because they're responsive to local needs. They allow for a better coordination of care and better allocation of scarce resources. They help us, if you like, bridge the two main areas of health, physical and mental health, essentially thinking about a more holistic approach to health, embracing essentially the biopsychosocial model of linking physical and mental health services together. But very importantly, as I always say, is that they are potentially scalable approaches to tackling the mental health crisis in our settings. So based on this best practice, we learned that there was a framework, there's an existing framework, which Craig and colleagues kindly evolved from their work in PRIME. This framework really looks at delivering mental health services across 3 to 4 levels, looking at about 5 work domains. So mental health at the healthcare organization level, very key players, specialist mental health services, healthcare service, but very importantly, also community-based mental health services. And based on this, what the framework enjoins us to do is to deploy and deliver mental health services in terms of creating awareness, ensuring that we improve our detection, our ability to detect, and obviously provide treatment and recovery models, but very critically also creating enabling environments. And so this was a very important best practice that we embraced in Ghana. But how did we do it in Ghana based on our learnings of these existing best practices and frameworks? So what we did in Ghana was that we tried to ensure that, and this was really aligning very closely with the philosophy of the Ghana Somubi Dwumadie program, which was to build systems. And so what we wanted to do from the outset was to ensure that there was obvious ownership from the outset. So we started with engagements with the Mental Health Authority of Ghana and the Ghana Health Services, who are the two main players of mental health services in Ghana. And in this, we formed technical working groups, but we also agreed on how the engagement plan would evolve going forward, but very importantly, also share with them our thoughts based on our learnings from the best practices of district mental health care plans and how they are done. Based on that, we formed this technical working group, and the task of the technical working group was really to come out with modalities or criteria of how we select the districts and obviously how we then plan next steps going forward. Having done that, we then continued our high-level engagements with the Mental Health Authority and the Ghana Health Services. We actually brought them to a stakeholder meeting where we shared with them our district mental health care plan framework, getting their approval, and if you like, a stamp of approval for us to continue, essentially to get their buy-in for what we were planning to do. But very importantly, also share with them the districts that we had selected and the rationale behind selecting those districts. Following this, having gotten this approval, we then were able to start with our regional and district entry processes, essentially that involve conducting situation analysis across the 5 districts, which I'll be showing you shortly, to understand what really were the district-specific needs so that the mental health care plans that are designed will be responsive. We also then formed important structures, one of them called the District Mental Health Operation Team, which was really the team that led the development of the mental health care plans. Having formed that team, we needed to build their capacity of what it means to actually develop mental care plans and develop theory of change maps. So we took them through workshops on theory of change, on letting them think through the step-by-step processes in which they would want to conduct their program of work in ensuring that people are able to access mental health services in their various districts. Very importantly, helping them to identify what really was the key impact they were looking for. And obviously also we try to come out with important outcomes to assess so that we'll be able to tell our story as to whether the district mental health care plans do work or not. Right. So, as I indicated in the previous slide, these were the 5 districts that we selected for this program to demonstrate that it was feasible to develop and implement district mental health care plans. And we were strategic and deliberate in this effort that we got approval from the key players in Ghana. So we see that Ghana segmented into 3 ecological zones, the savanna, the transition, and the forest. And so we selected districts to cover these areas. So we had one district in the north, another one in the middle belt, so one also to the west and the east, and obviously one to the southern western part of Ghana as well. But we ended up with doing the work within these 3 districts that are circled in red. Because of funding cuts and logistical challenges, we couldn't do this in all the 5 districts. So, but that is to ensure that we maintained our strategy to ensure that there was a balance and equity of this program across the 3 ecological zones of Ghana. So thank you so much. I would yield now to my colleague Kenneth, who is taking us through the next set of slides and actually getting us into the nitty-gritty and the nuances of how we actually went about the district mental health care plans, sharing with you some of the process data and information. Thank you so much.
Thank you, Benedict, for providing the context and background to the development and implementation of district mental health care plans. My name is Kenneth, and I'm going to talk you through how we actually develop and implemented district mental health care plans across 3 districts in Ghana. As a recap, the goal of our intervention was to increase access to mental health services through the integration of mental health services in primary health care. Our intervention is actually supported by Ghana Mental Health Policy 2019-2030. And district mental health care plan can be done and should be done. After securing the buy-in of national health managers that Benedict talked about, including Ghana Health Service, Ghana Mental Health Authority, we move into the district to form District Mental Health Operations Team, DMHCP. DMHCP is made up of representatives from the district, key agencies and institutions, including Ghana Health Service, Social Welfare, Human Rights Commission, District Assembly, Ghana Education Service, community members, including service users. After these teams were formed, we built capacity of the team through Theory of Change workshop. And Theory of Change workshop is actually thinking through and documenting how our intervention is supposed to work, why it will work, and who it will benefit, and the conditions that are actually required for it to work. And I should add that the DMHCP is actually a replica of what is supposed to be known as the district mental health subcommittees that were supposed to be in place through the enactment of the Ghana Mental Health Act 2012. But at the time of these interventions, these subcommittees were non-existent, and we needed to form the DMHCP to facilitate the implementation of district mental health care plans. The training was very participatory. As you can see in these pictures, that participants were actively involved in taking decisions as what they actually want to achieve by the end of the day. During the Theory of Change workshop, each district developed a Theory of Change map with an impact statement or a goal which they wanted to achieve at the end of the day. The teams that were identified in these Theory of Change maps included how to identify mental health service users, how to build the capacity of primary health care workers to increase access to mental health services, how to improve access to psychotropic medication, how to improve the economic well-being of people with mental health conditions, and more importantly, how to assess the progress of implementation. There were 3 levels that was involved in developing the Theory of Change map. And these levels included the health organizational level, where they identified the need for community leadership to provide policies that will ensure psychotropic medication supply and budget availability for mental health care. At the health facility level, they identified the need to train more health care workers to increase access to mental health services. At the community level, they identified the need to advocate for mental health services through DEBAs, radio and school mental health talks. More importantly, ensuring that people with mental health conditions are enrolled on government pro-poor policies, including National Health Insurance Scheme and Livelihood Empowerment Against Poverty LEAP programs. There were assumptions and the interventions that were put in place, and clearly there were indicators that were used to assess progress of the implementation. For capacity building for the primary healthcare workers, 84 primary healthcare workers were trained, on Mental Health Gap Action Program Intervention Guide, which is a tool developed by WHO to assess, diagnose, and treat people with mental health conditions. So these primary healthcare workers were trained on this tool to be able to identify cases at the health facility level. After the training, we provided supportive supervision and ongoing capacity building for the trainees. Sometimes the roads are rough, but we can do it with commitments. Apart from training primary healthcare workers, 87 community health volunteers were also trained to build their capacity to be able to identify and refer suspected cases of people with mental health conditions to health facilities for management. The other goal of training the community health volunteers is to ensure that we reduce stigma that is widely associated with mental health. We did collect both quantitative and qualitative data to assess the progress of implementing the district mental health care plans. For the quantitative method, we visited the district quarterly to review the healthcare plan to see whether or not they were achieving the targets that they set in the care plan. We also collected data from DMHCs to see whether there's an improvement in service utilization for people with mental health conditions. We conducted a repeat health facility case detection survey at baseline to check whether cases were being identified, and then at end line to assess whether we're now identifying more cases as a result of implementing the district mental health care plan. And I'll be showing that in another slide. For the qualitative methods, in-depth interviews were conducted with service providers and service users to assess their experiences of implementing district mental health care plan. In the next slide, we will discuss the emerging value of district mental health care plans and why we think that it is an intervention that should be scaled up to other districts for the purposes of increasing access to mental health services in Ghana. One key value is the improvement of detections of common mental health conditions. We notice improvement in management and referral systems, improvement in case history taking, improvement in psychotropic medication supply, and the establishment of district mental health supervision teams that are supposed to supervise the health facilities regularly. At the community level, we notice an improvement in relationship between traditional and faith-based healers and conventional mental health workers. We also notice that the involvement of the community health volunteers in case detection was key and actually enhanced case detection and prompt referral to the health facilities. There was also an increase in radio and school mental health talks and debates that aim to demystify mental health and improve mental health literacy in the communities. For the community empowerment, we facilitated the enrollment of service users on the National Health Insurance Scheme and the Livelihood Against Poverty program. Key tools were also developed to support implementation, including theory of change maps, SOPs for development and implementation, training and supervision manuals of community mental health service, and mental health gap intervention guide. Evidence from the process evaluation indicates an emerging value in terms of renew and strengthen interest in mental health within the districts. We noticed there was an active presence of district mental health operations team where they meet virtually and face-to-face from time to time. We also observed from our supervision that there was an improved competencies of primary healthcare workers to detect, manage, and refer people with mental health conditions. We also observed an enhanced collaboration between the community structures, including traditional faith-based healers, and community health volunteers where they refer cases to health facilities. These two quotes from two key stakeholders indicates that district mental health care plans are feasible, they are acceptable, and they should be implemented. From the district mental health coordinator and school health education program coordinator, they indicated that district mental health care plans are highly acceptable by all the key stakeholders, and that we need all hands on deck in terms of commitment to ensure that the plan are implemented to increase access to mental health services. From the baseline and end-line surveys, we recorded a relatively high prevalence of probable mental health conditions such as depression, psychosis, epilepsy, and alcohol use disorders. We also observe a low healthcare worker detection and treatment rates. However, we found no statistical difference in case detection rates between baseline and end-line survey. And the reason that may account for this is the fact that there was no dedicated fund for supporting the implementation, and also there was a short follow-up period for the intervention to have worked. Nonetheless, we also observe an increase in new case detection in the next slide, indicating that the intervention has the potential to increase access to mental health services. The number of new cases being identified per month from the intervention date till the end-line survey kept increasing, showing that the intervention actually works. What are the key strategies to implementation success? We observe that implementing district mental health care plans in Ghana faces significant challenges, but there are key variables that are crucial for its success. First is committed leadership. If the leaders are committed and interested in mental health, they will always find resources to support implementation. Allocations of resources is necessary, both financial and physical. We note during the implementation period that some health directors were able to find consulting rooms for mental health workers who were before then consulting in the open space. And this significant development was as a result of the implementation of the district mental health care plan. Third is there is an existing mental health policy that supports this intervention. The fourth is we note that strong key stakeholder engagement is key to implementation success. Because the district mental health operations team comprised of representatives from the key stakeholders in the district, coordination was easy for the mental health coordinator to push for implementation of the care plan. Also important is tracking district mental health information management data to see progress and actual plan for targeted intervention. The engagement of community health volunteers and identifying cases at the community level was key, as they were able to identify cases early enough and refer them for mental health care. I will stop here and refer you to my colleague Lionel, who is going to talk to you about the experiences of primary health care workers and service users on the implementation of the district mental health care plan. Thank you.
Thank you, Ken, for your presentation on the process involved in the development and implementation of the district mental health care plan. So after the implementation, we also wanted to explore the perception and the experiences of mental health service users and healthcare workers regarding the implementation of the district mental health care plan and the three demonstration sites in Ghana. So we conducted a study seeking to examine the factors supporting the district mental health care plan implementation, exploring the challenges impacting successful implementation of the district mental health care plan and examine the impact of the district mental health care plan in the 3 districts. So how did we go about it? So we conducted a qualitative research design using thematic analysis, and in terms of data collection, it was an in-depth interviews with healthcare workers and service users. So we interviewed 60 participants, 32 service users and 28 healthcare workers, 31 males and 29 females. So in Bongo, we interviewed 19 respondents, 11 service users, 8 healthcare workers. In Esunafo, we interviewed 20 respondents, 10 healthcare workers, 10 service users. In Aloga, we interviewed 21 respondents, 11 service users, and 10 healthcare workers. And in terms of designation, they included community mental health officers, midwives, registered mental health nurses, physician assistants, registered general nurses, and road nurses. So what are the factors supporting implementation of the district mental health care plan? So one significant factor that respondents reported to have positively supported the implementation of the district mental health care plan is capacity building. Respondents they discussed the importance of having a targeted training and the role the training played in empowering healthcare providers or workers and then community volunteers in providing effective mental health care delivery to service users. And so to them, it improved the skills and knowledge in mental health detection and management. And not only did it do that, it also increased the awareness and prioritization of mental health care within the district. Another factor was the acceptability of the district mental health care plan. So respondents explained that community participation and engagement has been a key component in the implementation of the care plan. So they specifically mentioned the role played by the local government representatives, which in Ghana we call them assemblymen, in taking leads in organizing people to attend the events organized by healthcare workers as part of the implementation of the mental health care. And then there's also evidence of community acceptance of the mental health care plan in the fact that healthcare workers are given a free airtime to discuss mental health issues on radio and raise awareness, which is a critical aspect of the plan's objectives of reducing mental health stigma and discrimination within the communities. Despite this, respondents also highlighted some challenges that they perceive to have influenced or affected the implementation of the mental health care plan. And one of such challenges is the inadequate financial support at the national level. So, and according to respondents, this has really impacted the overall delivery of mental health services within the country. And this challenge also trickled down to the facility level or the district level, where they are really having challenges in terms of financial support. And it's also impacting them in terms of carrying out their mental health service delivery. So, for instance, outreach programs are considered to be crucial for creating awareness and also identifying cases, as well as providing the mental health services that communities need. And the success of this is also dependent on availability of transportation, and then also fuel for health workers to move within these communities to offer these services. However, most participants that we interviewed reported a lack of funds or inadequate funds to purchase fuel, even when there's transport available. And this has really hampered their work. Another challenge that is also impacting the successful implementation of the mental health care plan is the issue of inadequate supply of psychotropic medicine. In fact, almost all the health care workers we interviewed mentioned inadequate supply of psychotropic medication as one of the main challenges that they feel is impacting the successful implementation of the mental health care plan. And this challenge has really impacted the ability to provide optimal care for individuals with mental health conditions. And not only that, it also imposes a financial burden on service users, as healthcare workers are forced to prescribe their medication for them to go outside the facilities to go and purchase this medication from pharmacies. And this poses a huge challenge on the people with mental health conditions, as it places financial burden on them. And this eventually also limits their access to mental health services. And then also another challenge is the fact that because now they have their prescription, sometimes they don't even feel they need to go to the facilities for checkup. All they have to do is go to the pharmacy to purchase the medication. And this also limits them in terms of they coming to the facilities. Despite these challenges, healthcare workers perceived that the district mental health care plans have had some level of impact within the district. And one such impact is the integration of mental health services into the primary health care. So participants explained that prior to the implementation of the mental health care plan, mental health was not fully incorporated into the different units of the healthcare system, and also inclusion of mental health services into primary health care was limited. However, the training of different cadre of staff who are not mental health nurses have helped them to really render some level of care. So, and as a community mental health nurse explained, if you go to the district and even some of the CHIPS compound now, there are other categories of staff who are not mental health professionals but can render some level of care. So they're able to assess, diagnose, and then even sometimes offer treatment or refer them for people with the experience to treat them and manage them. Not only that, it has also, according to respondents, also increased access to mental health services. Mental health services are now available at various levels, including the CHIPS compound, sub-district facilities, and health centers. And another impact that respondent alluded to was the early identification and referral of mental health cases. Now, healthcare providers, because of the training they've received, are able to identify potential mental health issues early, even during the general health consultation. So, first, most of the general nurses who were at the OPDs were not able to identify potential mental health issues, or even if they were able, they were not paying close attention to these cases. But ever since they received the training, capacity building, now they're able to identify potential mental health issues early and make the necessary referrals. So we not only did we talk to healthcare workers, we also sought to explore the experiences of service users. And we wanted to look at them in terms of the treatment impact. And one of the things they mentioned in terms of treatment impact was the reduction in relapses and then overall improvement in health conditions. So they compare their current situation to their former situation prior to the implementation, and then they feel like even though there are challenges in terms of medication, they still feel there's been a reduction in relapses and overall improvement in health conditions. There's also the increased ability to perform daily tasks independently, and they also have a better sleep pattern, which is they attributed to the effective treatment, and they feel like there's also been a reduced stigma and discrimination within the communities due to the awareness creation. So there were a few recommendations that we feel we could make, and one of them was to conduct longitudinal studies to assess the long-term impact of the district mental health care plan on service users' outcomes, including symptom remission, functional recovery, and quality of life. Because our program was just a 4 years program, we couldn't really conduct a longitudinal study to assess the long-term impact. So this is something that we could pick up in future research, and then also investigate the cost effectiveness of the district mental health care plan and its various components to inform resource allocation and allocation decision. So this is also crucial in terms of scaling up, because we would want to also know the overall cost effectiveness of the district mental health care plan in terms of the implementation, and that would also inform a decision. And then also we are advocating for government to also support in scaling up the district mental health care plan. So, concluding remarks. So, despite the challenges that are highlighted by respondents in the implementation of the district mental health care plan, the impact that respondents also highlighted have shown how valuable the plan can be. So, for instance, capacity building of healthcare workers and community volunteers has improved on the early detection and referral of mental health cases. And there's also been some level of mental health integration into the primary health care. So despite challenges faced by the service users, they've also reported some positive treatment impacts. So all these show how important the mental health care plan can be within the various districts. And if we're able to mitigate these challenges identified and then leverage on the positive impact that the care plan has shown, I think we can scale up this plan and reduce the treatment gap that we've been advocating for. So we would also want to acknowledge the following organizations. So Foreign Commonwealth and Development Office, FCDO, we want to acknowledge them for the funding and the support that we received. Mental Health Authority, Ghana Health Service, the various stakeholders, the various CSOs that we worked with, communities, Aloga, Bongo, and Esunafo. We also want to acknowledge them for the support they gave us, and then also our service users for also being part of this care plan. Thank you.
Great. Thank you very much indeed, Lionel, and also Ben and Ken for the great presentations. So we now have an opportunity to open it up to the floor, to hear your questions and to respond. Thank you to those who've already started posting questions in the Q&A. Just a reminder that those of you online can also post questions as we go. So what I'm going to do is just draw out the questions that have been posed so far and invite members of the panel of the team to respond. And I think the first question came from Ursula Reed, who's as I think many of us know, has done a lot of work in Ghana. She says, I'd be interested to know more about how the project improved the supply of medication and addressed issues of cost, as in my experience, this has been a key issue for many people. So I wonder if I could invite Ben, perhaps first of all, to respond to that, and then we can hear from others in the team. Ben, over to you.
Thank you very much, Craig, for this. And thank you, Ursula, for the very interesting and useful question. To start off, I would say this very clearly from the start. We we didn't objectively assess these shifts in psychotropic medication as part of after this. I mean, most of that would be really in line with what Lionel presented in some of the observations and the trends we were beginning to see. Having said that, I agree with you totally. It was a very critical issue, like as Lionel mentioned, when we started the whole program and we engaged in the TOC, this was a very thorny issue that cut across all the districts about the issue of psychotropics. And they didn't include that in their care plans, their theory of change. Now, you and I probably know, and many other people know here, that getting these things working come at many different levels. They did say very clearly that the change has to happen at the top level before then it's able to trickle down to the district. And I think that is one of the challenges of making some of these shifts. But we do have a session, Lila just reminded me, the program also did delve into the issue of psychotropics and did a lot of unpacking within the Ghana Health Service System and what's really going on. Do we really have a problem with psychotropic medications, or is it just something that, we keep flogging all the time? And there is some very good evidence on that, which will be I think there's another session that would be looking at that very, very closely. So you may want to look out for that webinar as well. But for the district mental health care plans, we would not have data specifically to talk to that whether we made shifts on that, because it was a bit complicated. And even though they have recognized that this is something they would want to have in their districts and wanted to see in their plan, it actually operationalizing it was a bit of a challenge. Thank you.
Great, thank you.
So the cost effectiveness, I think that's a very important question as well. And that is exactly what Lionel mentioned as, if you like, our plan for future research. We thought from the outset that we could actually include all that, but and indeed our protocol actually mentioned that to evaluate that as well. But there were quite a number of other challenges that didn't allow us to go into that level of evaluation. But on hindsight, we then actually realized that it's probably better to actually evaluate this, at a point after the intervention has probably taken root, and then we can begin to see whether some of these impacts are happening or not. Thank you.
Great, thank you, Ben. Ken or Lionel, do you want to add anything more on the psychotropic medication supply issue?
Yes, I will just add something. That's Ken. Briefly, yes, thanks. That's what we didn't objectively assess in terms of whether there's an improvement in psychotropic supply. What we did actually was during the implementation period, the DMHCPs, the District Mental Health Operations Team, actively engage philanthropics, where they get funding from the district assemblies and then the MPs and then other key members in the communities to buy psychotropic medication to support the treatment plan. This was not done before. So during that implementation period, the teams actually led that fight. And the other point that I would add is that normally when they send the monthly requests for psychotropic, for general drugs to the health facilities, they do not include psychotropic medication. But with the implementation, we have made it a plan that they should always include that in their monthly request for medication to the health facilities. So that actually also serves as an improvement in terms of the medication that come into the district. Nonetheless, we didn't objectively assess how that is, but in the interim, we observed that there were some psychotropics that came in, and that can be attributed to the work of the district mental health operations team. Thank you.
Great, thank you, Ken. So to summarize, I think it's some of the key learnings from us are that it really requires both a top-down and a bottom-up approach to improve psychotropic medication supply. Yes, we need the funding from central government, but also putting in the requests at a district level did seem to have an effect. And in fact, I think the Bongo district was able to leverage some funding to improve medication supply. So this is an ongoing issue, but just really encourage you to also look out for the other Ghana Somubi Dwumadie webinar, which will be coming up specifically on psychotropic medications. Okay, I'm going to move on because there are a lot of really great questions that have been coming in. So the next one also from Ursula is about, is increasing cases not necessarily due to the intervention? For example, there could be confounders like rises in cases anyway. Does anybody want to respond to that question? Perhaps Lionel, you haven't had a chance to speak yet.
Yes, so thank you very much, Esla, for the question. Yes, so you are right in some way to say that the rise is also, there's already rising cases anyways, so it cannot necessarily be attributed to our findings, but in certain cases too, within, because of the engagement that the engagement and the engagement with the healthcare workers, and then the overall, for instance, moving to the communities, the engagement with the community members, the education that they did also attributed to the increase in cases, because now it led to them more, there was awareness of identifying cases within the communities, because, and so for instance, community volunteers, within the period of reporting, there was an increase in their reporting suspected mental health cases to our district mental health care, the coordinators. And this was something that was not really being done. But after the training of these community volunteers, it led to this increase. And then there was also, if I could mention, in our supervision within the district, where I remember in one of the cases, the first supervision we went, some of the general nurses and the OPDs, those who were trained, they told them that they couldn't identify any cases. Then, so we sat down with them, then did a bit of refreshing in terms of what they need to do. And I remember, I think we were in the same communities. 2 days later, we came back, and one of them ran to us, came back with cases, suspected cases, where they had identified and then referred them to the appropriate authority. So this was something that, during our supervision and everything, we observed that there was an increase. So it tend to buttress what the respondent also said. I don't know if Ben and Ken also has
That's great, Lionel. Thank you so much. That really helps. I think, we didn't have a control group, but there are a lot of indications, as Lionel pointed out, that the increase in case detection and service utilization over time that we saw in the districts wasn't just due to other confounding factors. It seemed to be very closely related to the activities of the mental health care plans. Okay, wonderful. So just to say, for those of you who are clock watching, we officially have 4 minutes left, but we've been told we can carry on for another 10 minutes afterwards. So we're going to keep going with the questions. There are really great questions coming in. The next one comes from Chinwe Onumonu from Nigeria. And they say, many thanks for the experience sharing. Please, how were the caregivers or family members involved in the process? How were the referrals managed? So I wonder if perhaps we could go back to you, Ben, and see, did you have any thoughts on this?
I could, but I'd want to yield to Ken to start, and then I can come in.
Okay. Great. Thanks, Ken. Over to you.
Okay, so caregivers, family members were actually, from the start, when we formed the district mental health operations team, we actually included community members. And some of the service users were also part of that team that actually developed the mental health care plan that we implemented. And during the debates and the community that the team led, they talked to everybody in the community. When they organize the debates, the family members always come along with the service users, and there are sessions where they actually take them one-on-one to talk about the need to support the service users. Sometimes, because of the stigma, some people want to keep their patients in the house. But during the implementation, the health workers were able to visit the families and talk to them. They need to even take them to health facility for treatment, and then also support them take their medication, and the fact that they can be useful when they are recovered from these conditions. So that is that level that we involve the families, going to them to talk to them, and sometimes going to their communities and then their various homes to talk to users and family caregivers. And Ben can add something.
Oh, just very quickly, just to say that the program, the consortium also has a domain, basic needs actually led that bit of it, where they did a lot of interfacing with self-help groups, which are, as you know, dominated by caregivers. And so they were handling that, and we'll work obviously as a program, we're working together in that regard. So yes, they were involved and in the entire program. Thanks.
Great. Thanks very much, Ken and Ben. So the next question was, please, was the organization from Ali Mata Abdul, was organizations of persons with disabilities involved in the program? Maybe if I can go to you, Lionel, and then we'll circle back.
So for the entire program, there is also another I think site savers, and then we also worked with Ghana Federation of Disability. That's for the program. That I'm sure site savers has a presentation on that particular aspect. So the program is involved disability, work with persons with disability organizations. So, but with ours was specifically with the healthcare workers, the operation team members who were the main implementers, who were just giving them support and building their capacity, and then the service users, and then the social welfare department who also worked with disability organization. So we were looking at more at how do we empower them, ensure that we enroll them on LEAP and national health insurance. So yes, so that's what we did.
Great. Thank you, Lionel. Just in the interest of time, I'm going to move on to the next question. So there's another question from Ali Mata Abdul, and they say, please, in addition to what has been shared, were there additional factors that influenced the selected districts, or I think it's the selection of the districts? Ben, maybe as you spoke to that earlier on, do you want to respond on this issue?
Yes, sorry if I wasn't that very clear, but yeah, so the factors that we actually relied mostly on the criteria that were set by the Prime program in selecting districts or areas for demonstration projects like this. And so very much in line with ensuring that there's not so much already existing mental health activity going in there. If not, then you wouldn't be able to see any changes. So that was a cardinal reason. So we selected districts where they were, so it's in between. It's not that overly, competent in their way of delivering mental health services or too low. So they're in between. So these were important factors. We also looked at, obviously, leadership and, where we think that there are quite possible leadership issues or challenges, or where leadership is well grounded. So some of these factors went into, but we were definitely guided by the Prime framework in selecting some districts. But for us, like I said earlier, what was important is to ensure that there was a spread. Given the way Ghana is laid out, most of mental health services are concentrated in the southern belt, and so we wanted to ensure that we were able to demonstrate that mental health care plans can also be implemented effectively, even in areas that are known to be underprivileged. Thanks.
Right. Thank you so much, Ben. Let's move on to the next question, which is from Nafisa Garba. And they say, does your team include a physiotherapist? And if no, why? Ken, can I pass this one over to you?
No, we didn't have physiotherapists in our team. Yes.
Yeah, and I think it's very true to say there are very few physiotherapists in the districts in which we worked. Is that right? Is that right, Ken? Can you hear?
Yes. So, I mean, where there's a need to refer, I mean, there are very few in the country actually. So, where there's a need to refer, there are clear referral pathways where the district teams are able to refer people who actually need those services. But our team, as it is, didn't include that.
Okay, great. Thank you. So there's another question now from Darlington Aduse. The question is, did the community health workers utilize any digital health solutions? Very interesting. When interacting with individuals with mental health issues, or were all services provided exclusively in person? Lionel, do you want to respond, and then we can see if anyone else wants to add?
No. So first off, the community health workers, what their main mandate was identify the suspected cases and then make a call. So call the district mental health coordinator or mental health nurse within the nearest facility, and then the health worker will take it from there. So theirs was to identify and then provide education to community members, and then we would make the call. So we didn't really use the digital. So maybe Ben and Ken.
No. Okay. I mean, I think it's a great idea. It's something we could think about in future. And I think if we had more funding and potentially for a future program, it would be great to start including digital tools for community health volunteers. And I know this is being piloted in other parts of the world. So it's a great suggestion. Thank you. Right. The next question is from anonymous attendee, who says, in unpacking challenges within the health service, and in particular with access to psychotropic medication, how did your project evaluate access for vulnerable groups such as people in correctional, detention, social welfare centers, where gender-based violence against women victims may be, and prison settings, etc.? These populations may not be able to afford to buy them. Interesting question. Thank you. Ben, would you like to respond to this? And perhaps.
Yes, it is a very interesting question. And I guess, again, as Craig said, these are just great opportunities to look at, create opportunities for further research going forward. Our district mental health care plans were very, very driven and led by the districts and the MOTs that were formed, and we were just to guide them in terms of the processes and thinking through building their competencies around that. And most of the plans that really just focus on, if you like, strengthening the community component of things, but also health facility. They didn't specifically look at these special groups, as you mentioned, or populations, as you mentioned. But I think this is something that we could really pay attention to and ensure that equity, mental health equity, is maintained across, and ensure that even vulnerable groups like this are also attended to in this mental health care plan. So very, very good learning and suggestion. Thanks.
Yeah, thank you very much. Just to echo, I think our intention with this was to really look at general populations in low resource districts that were identified by the various stakeholders. And once we've been able to prove a general population concept, I think definitely the next step would be to move into more vulnerable populations. So thank you for that. Okay, I think we have just about 3 minutes left, so let's move on to the next question. I'd like to know about the involvement of traditional and faith-based healers. This is from Bisola Oladele. How were you able to convince them to collaborate? So, Ken, what's from your side?
Yes. Yes. So we already have, the districts already know where people with mental health conditions go to in terms of seeking traditional and herbal treatment. So they compiled a list of these herbalists, and then the approach was to tell them that, yes, you can take care of sometimes the psychological needs of the patients, but when it comes to the physical needs, let's work together. So there are times where the traditional healers, once they get to understand that you are not actually coming to take off or make their job useless, but you want to collaborate with them, then they open up. So there are cases where traditional healers are able to refer cases to the health facilities for physical treatment sometimes. And then in other places, once the person is deemed stable and still want to go and see a herbalist, there shouldn't be any reason to stop that person from. So that kind of collaboration existed. And then they also take the traditional healers through what they describe as trying to let them understand why they shouldn't abuse people with mental health conditions, especially chaining them and trying to beat them to exercise the bad spirit in them. That is something that they educated the traditional healers not to be engaged in, because that amounts to abusing the human rights of patients. So that collaboration works for a lot of them.
Right. Thank you very much, Ken. All right. So I think we just have one last question, which is from Adam Dokurugu Yahaya. Good to see you, Crick, Ben, Ken, Lionel. I'm excited that this program happened. Basically, Ghana is glad to be associated with it. From the point of KCL, what could be done differently with the experience and lessons from this program? Well, I could answer, and then I'd be interested to hear, Ben, Ken, Lionel, your thoughts as well. I think what would be really helpful as a next step is to start scaling this model in other districts and to see what other lessons we could learn from this. A key for me has been some of the barriers around psychotropic medication supply. I think if we could really overcome that, we would go a huge way to improving the quality of life of people living with mental, neurological, and substance use conditions. And then I think, as Ursula alluded to, it would be great to do a larger scale evaluation. As Ben mentioned, we did have this plan. We were going to do cohort studies. Unfortunately, there were budget cuts, and so we weren't able to follow through on that particular study design. But it would be great to do a large cluster randomized controlled trial, where we have intervention districts and then control districts, and we look at changes in detection rates, changes in mental health outcomes, comparing those districts over time. So that would be the next exciting phase, I think. And I certainly hope that other opportunities come along to work with basic needs and to work with all the different stakeholders in Ghana that we've been able to be and privileged to be involved with in this program. So thank you for that. Ben, Ken, any final words? Lionel, from your side before we wrap up? I think we're just about out of time. Ben?
Okay, thank you very much. No, I totally agree with you. I think these are exciting times. We've demonstrated, and I think by and large that it is doable. And Prime has provided that leadership, and we've also learned very interesting things in Ghana, and we think we can really take this forward. We have lots of tools and packages that we've developed that we can definitely share for future projects like this. So thanks.
Yeah, I associate with Ben's remarks. Thank you, everyone.
Great. Thank you, Ken. Lionel?
Yeah, I also agree with what everyone says. And I think it's actually the impact. We're already seeing the impact where now the districts, some of them are now taking it up, trying to scale it up to the next, the nearest district, so which is encouraging. So it shows that indeed there's ownership, everybody's taking it, so we can really scale it up. And it's not that expensive.
Right. Thank you, Lionel. Thank you very much. We had a very exciting dissemination meeting in Accra in early June where all the district operations teams came together to share their experiences. And it was just wonderful to see the energy in the room and the enthusiasm from the districts who've really taken this program and really run with it. So thank you. Especially want to acknowledge all of their involvement, their leadership. And it's been an absolute privilege to work with everybody. So thank you. I think we'll wrap it up for now, and please do share this. I think the video of this presentation will be made available to all who attend, and wishing you all the best in all of your ongoing work. Thank you so much. Bye.